Hello, everyone. My name is Francisco Ujueta. I'm a clinical vascular fellow at Brigham and Women's Hospital. This is Dr. Kim Smolderen.
Hi, everyone. I'm with Yale University. I'm a clinical psychologist and outcomes researcher. Glad to be here.
And we are going to speak about the New American Heart Association statement titled Understanding the Pain Experience and Treatment Considerations Along the Spectrum of Peripheral Arterial Disease. This paper started as treating patients with PAD. We many times are encountered with this situation of treating or managing patients with pain. And many times we go into the barriers of what type of pain these patients are encountering and what medications we should use. I came with the situation of trying to ask my peers, and many times my peers were hitting some roadblocks. So I thought, why not commission a group of experts and try to get a hold or better understanding of the pain that patients with peripheral arterial disease are experiencing and understanding a little bit more of it. I was fortunate enough to get a hold or get connected with Dr. Kim Smolderen from Yale and Dr. Carlos Mena, who have great experience in managing and treating patients with pain. We were able to put a great team together to better understand for myself and also hopefully for the readership in how to manage understanding the pain in peripheral arterial disease and going forward, hopefully building research when it comes to patient centered outcomes.
Yeah, no, thank you for that introduction. I remember you reaching out to us, and that came at a really perfect timing. Carlos Mena, who is also on the statement as a senior author, he at the time came to me as an interventional cardiologist. He said this pain problem is really a big issue in this population. And then certainly also he saw a connection with high opioid use in his population that he was treating. And me coming from this problem from a perspective of psychology, and him and others having lots of experience on dealing with the ischemic problem, we were able to highlight the multidisciplinary aspects of pain. And often in treating people with PAD, we forget that it is more than an ischemic problem. Pain processing is not happening in the periphery, in the legs. There's cognition involved, there's behaviors, and then a lot of comorbidities that play a role in the pain experience and complications of it as well. So that was just the right moment to start really reflecting on this problem from a bio-psychosocial perspective. And I think we were very fortunate, as you said, to pull together these experts, some of them international experts on chronic pain. And I would argue that PD is perhaps one of the later chronic conditions where we're starting to think about pain, the chronic pain aspects, and thinking through the multidimensional aspects, because in other chronic pain conditions, it is becoming more standard practice to see this as a multi-level problem.
Many times we as clinicians think of anginal type of pain when we look at the heart, that just opening the occluded artery, we are treating the problem. When it comes to a chronic pain condition, as this should be classified and thought of, it needs more, a little bit more understanding and a little bit more multidisciplinary of treatment or how we tackle the problem. This paper will go over a model of modal pain management strategies, which we entailed in Figure 2, that takes different aspects or different barriers when it comes to pain and PAD. Those are biological factors such as psychological stimuli, ischemia, wounds, nerve damage, inflammation, and non-PAD comorbidities and risk factors, as well as social issues, as well as social factors such as social support, culture, social determinants of health, and psychological factors that patients may be dealing with, such as mood, behavior, and also pain perceptions.
Yeah, and I think to add to that, what we discovered is that there's not really a great pain assessment tool for PD to capture these multidimensional aspects of pain. It's very complex. It's a matter of the ischemia. There may be inflammation involved, and neuropathic pain as well. So all of those aspects require more fine-tuned assessment, as well as the psychological factors to capture elements that perpetuate the pain. And we took a look at the health status instrument that are currently available for PD. There is some assessment on pain intensity and frequency, but not capturing all of these dimensions. So certainly, I think what we stated earlier, also, we would need more dedicated efforts to coming to an instrument that captures the pain experience in PD um, in that multidimensional context. We do provide assessment tools, suggestions for chronic pain assessments derived from other chronic pain conditions that capture some of the psychological factors that, for instance, fear of pain and the perceptions that people hold regarding their pain, how long it's going to last, and how their behaviors impact sustainability of the pain they experience. Oftentimes, people may experience fear associated with pain, and they're going to restrict movement as well, which, as you can imagine, in the context of PD, is not ideal because we want them to walk through the pain and start moving more. When we wrote this up, we approached this from an ideal case scenario, and having all the perfect elements in place to approach this as a biopsychosocial problem, and also offer insights on treatment and interventions that can alleviate pain besides invasive treatment, beside pain medications. There's also the psychological interventions, behavioral interventions. Going back to your clinical practice, what do you think needs to happen for you to integrate some of these insights?
PAD is very undermanaged, underdiagnosed first, and undermanaged, as you know, patients are not on the good medications, meaning statin antiplatelets and those type of things. I think the next thing is the need for proper way to assess pain in patients with peripheral arterial disease, and then from there, you know, we are able to either treat patients depending on our background with the pain medications that are needed. Again, different medications for pain treat different things, right? Neuropathic and somatic. And if we're not able to, we have great specialists like yourself and other people as that participated in this statement, for example, that have more background in pain, and we need to use all our resources to try to tackle pain and peripheral arterial disease.
Right. So, right now, the treatment for PED is primarily focused on managing the ischemic problem and the risk factors surrounding it. As we took a deep dive in the aspects of pain and discovered more elements play into that, behaviors, cognitions, people's mood, and how they reinforce their beliefs in their day-to-day actions. Do you think PED will evolve to be more than an ischemic problem? And how will teams of the future that treat PD look like? And especially also with the complex metabolic context and other comorbidities that people are dealing with.
I think that having, for example, a supervised exercise therapy, as important as it is, you know, many patients aren't really referred to it, or many institutions don't have that set up. So that's one thing to keep in mind. But awareness is key, and then bringing different, again, multidisciplinary teams in there. Again, you know, different hospitals, depending on their resources, are able to include, you know, internists, dietitians, endocrinologists, vascular medicine physicians, cardiologists, IR, interventional cardiology, as well as vascular surgery, podiatry to help with the wound care of these patients, but as well as, again, like you stated, psychologists, psychiatrists as well, to try to help with the chronic pain syndrome as well that will give us a little bit more insight into what they're dealing with. This statement will bring in further research and person centered outcomes when it comes to how to deal with AD.
I'm curious, were you surprised to find out that the opioid use in this vascular population is so high? And maybe that's not on our radar enough, and that should form a stimulus to find more innovative interventions besides the current ones we have available for PAD pain relief.
Many times these opioids are not even managing patients appropriately because many times it's not really what we're treating. It's not really ischemic pain. Again, research in PAD a lot of times is extrapolated from the CAD population, the coronary artery disease population. So recently we've seen with the dual pathway inhibitions, there's been a kind of a bigger interest in PAD research. And hopefully this statement will again recharge the interest in putting more funds when it comes to PAD research and in pain and different things when it comes to the management of these patients.
Yeah, I think that's a very good point to make. The interaction with pain medications and opioids and vascular function and people's symptomatology. We just don't know much about it. And I think it forms a fascinating direction for future intervention, one that can, a research, one that can open up pathways for innovative interventions for this population.
We had the PAD guidelines completed last year. There was not very much on pain when it comes to how to manage it or how to treat it besides revascularizing the patient. So I think there's a lot to do in not only, taking it back to our own clinics and our own patients, but taking it back to our colleagues and, letting them know that it's not all ischemic pain, but we need to make sure that we're looking at neuropathic pain and other avenues of as well to tackle this disease process.
Well, I really enjoyed the collaboration with you, and thank you for bringing this project group together. I look forward to doing more work on raising awareness on this topic. And yeah, it was a great experience for all of us. Thank you.